Good afternoon, everybody. Thank you for being here and joining this webinar. I'm glad you have interest in our today's topic, which is on the accelerated orthodontics with pulsatile forces. Where is the evidence? We ask the question. My name is Dubi Pavlin, and I will be presenting today and hopefully initiate some thoughts and give some information that will be useful to clinicians. I'm a professor of orthodontics at the School of Dentistry in San Antonio and in private practice in San Antonio. And for today's lecture, I would like to focus on a couple of aspects of our topic, specifically in general terms, discuss a little bit about evidence-based treatment. How do we as clinicians decide which techniques to use? Then look at some of the systematic reviews on the topic of accelerated tooth movement. And I put a subtitle, In Search of Evidence. We are all searching for the evidence, and we will look into those reviews and what can be learned and how to discern better the evidence from them. I will focus on the randomized controlled trial, or RCT, that we did in San Antonio, and the effect of vibration on the orthodontic tooth movement, and present on that with some case examples followed. And then point maybe us in a direction of future and say, what do we look in the future studies? What do we look for when we read, search for articles, and try to discern how to find the best evidence that we can apply for our patients and in treatment in our practices and university clinics. Evidence-based treatment, a buzzword for over probably 15, almost 20 years now. We hear it all the time at the meetings. We read about it. A lot of titles and abstracts of our papers have the word evidence. It's almost like it has to be there. But what I would like to ask you is, what comes to mind first when I say evidence-based treatment? You probably go in your mind through the pyramid, which I will flip upside down and start kind of in the bottom. What is in the bottom of our pyramid of evidence, a level of evidence, and evidence that we search to discern the best treatment for our patient? We think about case reports. Those are important. In the past, they were predominant or the only thing that practitioners had. We think about retrospective study, which at the time when I was a resident, and probably many of you were predominant. When we did have a study, it would be somebody going in a clinic, pulling the charts out, counting the patients, and say what happened with this group of patients. They were very valuable. Retrospective studies went done on, position of canines and changing position or not, and during the orthodontic treatment, Little's index and all that. This kind of studies were all the essence and the very strong basis of what we have in orthodontics today. But then we started looking at the medicine and the general medical field and the dentistry and say prospective studies are something that we should be looking for. We did not have that many in orthodontics, and frankly, we don't have that many prospective studies. But what are we looking for when we say prospective studies? Prospective study of a high quality should have controls. There has to be two groups. There has to be treatment group and control group that is established. It follows the treatment group from the same population. They have to be randomly selected. Patients need to be randomized. The process of random selection is essential for any quality study. Look for that, how it was done, whether information was concealed after the allocation of patients was done or not. They will all point very early in the paper as you read it, whether this group have done a good job in designing the prospective study. Essential component are the investigators blinded. Double blind is investigators and patients are blinded. Nobody knows exactly where is the treatment and where is the control and what is supposed to be doing. So being blinded is essential component. And then what is the intervention? How is the intervention or the process or the appliance or drug, whatever we're looking at, pharmacological effect, how is it designed? How is it selected? What is it? Are we asking a specific enough question that would lead us to a specific answer? very important one that I will spend some time talking about later, was account taken of the patients that did not complete the study, okay? Complete account of patients that went through the study and those that do not. ITT and per protocol groups, I'll get to that in a moment. If we have these components, we get to the gold standard of in today's literature of clinical studies, randomized controlled trial, or RCT. I will report on one of them and mention the others, and through reviews we'll look into that. And what happens when we have several RCTs on a certain topic? Then we get information together and we do systematic review. Systematic review is different than just a review. In residency programs, in the clubs, we have reviews. We discuss, we agree or disagree, but systematic review sets up the criteria and criteria for inclusion of patients, and then statistics is done comparing different controlled trials. In systematic reviews, unfortunately, we cannot have only randomized controlled trials because specifically in dentistry, but in orthodontics in particular, we do not have enough RCTs on any of the topics that we can do only systematic review on RCT. Systematic reviews would include these days also retrospective studies and low-level evidence studies, and we'll get to that in a moment as we go through the examples of these reviews. And finally, what crowns it all is the meta-analysis. When you have enough good quality studies, then you can do better than systematic review. Review called the meta-analysis that has a higher level of scrutiny that gives more information but requires many more studies and participants in these studies. So as always, you gain something and you lose something. If you go to meta-analysis, the information can be more useful, more conclusive, but the data, the number of studies needs to be higher. And finally, now if we go back all the way to the bottom or to the beginning of that list, what about anecdotal reports? What about you joined with Jack, and Jack says, I have been doing this procedure for 27 years, you know, and you're straight out of the residence. This works in my hands every time. Try it and you will see. And you look at him and you watch him doing, and it works in his hands. Well, that's an expert opinion. He didn't do a study on it. He just said, in my patients it works. It works in most of my patients. I had really problems with it. Well, that's an anecdotal report. Do we need to discard these because we're now we're striving toward controlled trials, RCTs? No, we should not discard any of these, which are on the bottom, if you wish, and not as high quality, because they're still useful. And we'll discuss this a little bit and hopefully put it in perspective at the end that will be helpful for future discernment on how to go about looking for evidence. So instead of saying, well, this is evidence-based treatment that I'm practicing in my practice or in our clinic, why don't you say, well, this is the level of evidence that I need and I like to have in order to start using certain procedure. So each of us clinicians must decide which level of evidence we will consider sufficient for starting to use a new approach or technique in our practice. It's the level of evidence we need to focus. In some cases, if we don't have any better, it will be a retrospective study, or the word from our colleague, from our teacher, from people who have done a lot of cases. We'll go through a couple of case reports later, which carry information and are evidence to some extent how certain appliance, in this case Accelerant, works. So this level of evidence is important. And another question that I want to ask you at this point, as clinicians, take a few seconds to think about it. What do you think? Which level of evidence are the basis for most of the treatments in orthodontics today? Which level of evidence? On the list that I gave you that we went through and we talked about, which level of evidence are we predominantly in our practices, in the techniques that we use, approaches that we use, adjunct procedures, and everything else, okay? The answers will probably vary, okay? But we are definitely not at the level where medical field is, cancer, research, cardiology, you know, life-threatening diseases. They have to look at the much higher levels of evidence before they can claim to the patients, to the public, that something is safe and that this procedure is based on high-level evidence. So what am I saying here? That I'm not putting our great profession of orthodontics down and saying, well, we really are way behind in this and we shouldn't be really trying. We have to try. I teach residents. I tried myself to introduce in my practice and in our daily living as much evidence as we can. But we have to be realistic. We don't have that much of it at this time, and every good evidence in clinical trial is welcome. So my suggestion, something to think about, would be that we attempt some consensus as to which level of evidence should justify clinical use of a new technique. You agree with your colleagues in your practice, with your study club in Houston, San Francisco, wherever you may be, and you say, well, this is something that we would like to see as a level of evidence before we start using this new technique that is proposed to us. And finally, I would also like to throw in here an idea that I think would be greatly helpful in review of papers for our journals, that reviewers of our journals should be at least to some extent calibrated on the level of evidence that is acceptable for the journal for certain types of studies, that in order to provide better and unbiased reviews. I know it's hard thing to do and it may take time, but an effort should be put in that direction. So I hope that this approach to looking at the level of evidence, deciding what is important for me individually, for the group or practice where I work, or clinic, university where I am, when I am faculty, I think this would at least initiate some thoughts in your mind about using the level of evidence as a gauge to gear and direct our thoughts toward when we decide about new procedures. Let's look at the example of systematic review published in 2013. Long is the first author, published in Angle. And I will just mention it at the beginning, an example, give you an example. This is the systematic review on accelerated tooth movement, on techniques used for accelerated tooth movement. I want to start by saying that they included in the final review 9 articles. They started with several hundred exclusion criteria, then they narrowed it down. They excluded articles that for one reason or the other were not fitting and not meeting inclusion criteria. And they ended up with 9 best articles in on different topics that they included in this review. This is not one uniform approach. They talk about low-level laser therapy, corticotomy, you can see surgical assisted orthodontics here, electrical stimulation, dental alveolar distraction, and also the pulse electromagnetic fields and so forth. So there are several procedures and there are 9 articles. Small number and different approaches. How is the systematic review going to review that? They did a very good job, given that the materials, as you can tell, was not very abundant. This is what I was trying to tell earlier. We do not have in orthodontics yet a sufficient number of studies and enough evidence that we can do good systematic reviews and meta-analysis. However, this effort was, is great, and we need more of these type of studies. I'll get back to these studies a little bit later, but at the moment I like to go to our study in San Antonio and start presenting on the RCT, randomized controlled trial that we did. The principal investigators were Ravi Anthony and Peter Gakunga, our former residents, today full-time faculty in our department. I was a consultant with the Orthodontics since the beginning, and sponsor and funding was provided by the Orthodontics Technologies. I have to make a disclaimer here that as a consultant before FDA and just before IRB and in general, I was not allowed to, not attempted to treat the patients, do anything about the treatment of patients, participate in data collection or interpretation of data. I was just in general terms consulting about the study protocol, which I have designed together with some other colleagues, and I was out of the study as an investigator. So I have to make that disclaimer right away. Here it is. This is the actual paper, came out just this month in Seminars in Orthodontics on cyclic loading or vibration to accelerate tooth movement in orthodontic patients. Double-blind randomized controlled trial. So right in the title it says, okay, we have here major components right here. Notice that vibration, cyclic loading, pulsatile loading, these terms are basically referring to the same thing, to a force that is applied in some cyclical way, as vibration is probably the most commonly used term of cell phones vibrate or toothbrushes vibrate. So this is what it does. It pulsates. And this is also published online. I will refer to it, and want to emphasize right away that this presents only one aspect of our trial, and that is retraction of a canine and movement of a canine into the extraction space. To the background for that study, again, and the study is published now, so I will go quickly to some of these sections. There was a lot of approaches that were proposed historically to accelerate tooth movement from different pharmacological interventions. We've all heard about them one way or the other. Laser radiations, pulse magnetic fields, surgically assisted orthodontic procedures. And the excitement for each of these was great when the first papers were published, whether in animal studies or in humans in some cases. But then when we started looking by the criteria that I was mentioning in introduction, and by the criteria that is review that we are going through right now together, is looking for the evidence to support clinical benefits was very difficult to find. Why is that the case? Because it is much easier to do a good study and present that something has an effect in an animal model or in a cell culture system or in a low-level, low-quality study, clinical study, then do a rigorously conducted clinical trial. That's why the evidence is still lacking for most of these procedures. The rationale to initiate the study on vibration comes from two sources. The first is orthopedics research. For a number of years, prominent orthopedic researchers such as Clint Rubin, Charles Turner, and many, many others are actually looking at the long bones, primarily from the standpoint of fractures and osteoporosis. And they have established that the long bones respond to low-level vibrations, pulsatile oscillatory forces, again, different terminology you can use, by increasing bone density, and that this decreases bone loss. Very good news for osteoporosis. Today, if you have a treatment on the cervical spine, if you have surgery, they will put vibration on that to heal it faster. So this is one of the examples, called also the granny shaker, vibrating plate, where in this case, patient, she's a little bit too young maybe for osteoporosis, but we don't know. But this patient is standing on the plate and enjoying vibrations through her whole body to initiate what? The dynamic loading of her bones and spine, which leads to higher bone density and builds up bone strength. This is called, in orthopedics and bone biology, anabolic effect. Anabolic means better metabolism. The things are happening faster, the bone is being remodeled faster. This is what everybody wants to have. Okay, so this is one line of evidence which was the rationale. Another line came from animal studies, primarily Dr. Jeremy Mao with the pioneering work in rabbits, showing that cyclic force increases sutural width and periosteal bone formation. And then in 2008, just about when we were submitting our protocol and starting with FDA in this study, Nishimura published paper in rats expanding the maxilla and actually finding that with vibration the amount of tooth movement, these molars that are moved buccally, actually increases, and also looking at biology that the number of bone cells, the osteoclast, has increased in that model. So from both of these lines of evidence, we concluded that we do have a rationale, and the rationale would be that there's no need really for invasive adjunctive procedures in orthodontics, such as perforation of bones, poking holes, cutting incisions, and doing these surgical procedures, if a simple and non-invasive, patient-friendly approach can accelerate tooth movement to a similar degree. So why not to do a study to see if this is possible? That was our major rationale. So the cyclic loading, as I already stated, of vibrations reverse bone loss in patients, with osteoporosis and increase the tooth movement and expansion in animals. We started from there, and we went on with the designing clinical trial, which up to that point there was none available in that particular topic. The hypothesis that we devised was that the application of a specific type of cyclic loading by the Accelerant device for 20 minutes per day will increase the rate of tooth movement when applied in conjunction with conventional orthodontic treatment. Two key points here. One is that this is to be specific type of cyclic loading. This means that you cannot bite on your cell phone when it vibrates and say this is gonna make my teeth move faster if I have braces. You cannot go and get electric toothbrush and start brushing your teeth more frequently. Say this is gonna make my teeth move faster. Or you cannot get over-the-counter appliance that is supposed to be just soothing the pain in orthodontics to say, well, this can move my teeth faster. Specific type of loading which we applied was based on very, very thorough and really a lot of orthopedic research, and those type of studies have to be based on that specific type of loading. So on the basis of that hypothesis, the aims of the study were to define whether controlled pulsatile loading of our braces will increase the rate of tooth movement and the rate of initial alignment, whether this is safe or are we going to cause some roots to be resorbed in our patients, which is what we always fear in orthodontics. You don't want to resorb roots. And to measure ease of use, how the patient perceives these appliances. The design of the study, if you compare this list from what I've shown earlier, a pyramid of evidence and a hierarchy of evidence, it was prospective, double-blinded, randomized, fully randomized control trial. And the Accelerant was used as a complement to fixed braces, in other words, as a part of treatment, as an adjunct treatment. Just a note, it could be done with any types of the appliances, with aligners, with removable aligners, and any type of fixed or removable appliance as well. Very uniquely, the study was approved, pre-approved by the U.S. Food and Drug Administration, by FDA, which, according to my knowledge, was the first time that it ever happened that anybody has initiated study, and they were seeking and obtaining the approval for FDA, meaning that FDA said, good, this is good enough, whatever evidence you get for this, yay or nay, positive or negative, we're going to take it. And this is how the study was started. So also the study meets the consular requirements. That is consolidated standards on reporting trials, agreement in the biomedical field, medical, dental, and all other fields, pharmacological fields, they agreed and publications were published that certain standards need to be met for the study to be called randomized trial, and those are basically the ones that I already outlined that we went through a little bit earlier, okay? So in our study, the inclusion criteria for our patients were that they had to be between 12 and 40 years of age. We included actually some teenagers and some adults in the study. Upon the request by the FDA, we separated them in a group and looking at differences. There wasn't much of a difference because the groups were not large enough originally to look at those two age groups, but we did include both growing and non-growing patients, and it turned out to be, when we looked at the stratification of data, that there wasn't such a big difference in age between these patients. Another inclusion criteria was that patient had to have extraction of at least one maxillary first bicuspid. One premolar had to be extracted according to the treatment plan, and the posterior anchorage needed to be maximum, meaning we don't want to move back teeth forward, only close the space as much as possible by moving anterior teeth back. Those are the basic requirements. Now, after the alignment and the extractions were done, we needed some space in which we would move that cuspid, so we established one of the criteria, at least 3 millimeters of extraction space needed to be present for the inclusion in the study. Exclusion criteria are pretty standard. We didn't want to have any patients with periodontal disease or any condition known to affect tooth movement. We didn't want to have patients on prescription medications or pregnant women, and this is how the patients were selected. Let's look at the patient sample now and kind of connect that with the study and a systematic review of the studies that we'll be getting back to in a moment. In our sample, we had a total of 45 patients. This group is called intent to treat, meaning everybody who was enrolled, we enrolled them with intent to treat. It's called the ITT group, okay? Now, as it happens, not everybody will finish that way. In our sample, 6 patients didn't finish that way. But remember what I told you about accounting for all the ones that didn't finish? That's essential component, and we have it. It's right here. These patients were out. These are not the ones, these are the ones that were up here in that group, but not in this group. Per protocol group was group only here and in this column right here. And we say for each of the patients what happened. In this group, 2 of them, the TADs failed. They became mobile because of poor oral hygiene. Same thing over here. One lady was pregnant, so she couldn't continue in the study. But the rest of the patients, subjects were started. 39 of them were in this group. Which group is more important for analysis? It's this one over here. According to CONCERT, we need to look at all the patients, all the subjects that have been originally included. We have to interpret the data. And you know, at first, it may not be intuitive, and a lot of clinicians come and say, well, it doesn't make any sense to me that you included this lady who was pregnant after she was enrolled and found out that she was pregnant. She didn't even get the appliance, and you're including her in your analysis. Yes, we have to. Well, guess what we get? We get 0, 0, 0, zeros because the tooth movement with the accelerant, there will be 0 recording because she never got the appliance. But the point is that this happens in the real world, in the same samples of patients in clinical situations, and this is the right way and more meaningful way to interpret. So I will focus mostly on ITT group, but show you both sets of data. Back to the systematic review now, how we tie it with our study. I want to show you one thing here. We just said 45 patients and how we divided them. By the way, our power analysis requested and asked only statistically for 32 patients. We went to 45 just in case, and we're very glad that we did. Some patients dropped out, as I showed you. But look at the sample. This is the top 9 out of hundreds of samples, studies on accelerated tooth movement techniques and number of participants in this study. They go from 6 to 7 total. 6 meaning 3 plus 3. 3 in 3 to 3 control group. 10, 12, and 20 at the best. Okay, so what does this tell us? This tells us we need to be realistic about what we have in terms of high-quality evidence in orthodontics today when it gets to accelerated tooth movement. And all topics, all subjects in orthodontics are pretty similar to that. Periodontics have more because their studies are easier to design, they're cheaper, a larger number of patients. Just the nature of the profession. Our treatment is 2-3 years long, and it's just orthodontics is totally different animal when it gets to collect a large number of patients and do it systematically. So here it is that looking at accelerated tooth movement, the sample sizes were in general very small. So we thought, we felt good, we were pretty good with our study, that we are going with 45 patients, and it turned out to be statistically more than sufficient number. Another aspect that you need to look at when you look in general any study or set of studies for systematic review is how does the technique itself work? How is the technique presented, and how clear it is how the measurements were made? What is happening here is that there's a question about anchorage. And anchorage in a lot of these studies was not even specified as to what happened with it. If you're closing space between the back teeth, which are anchorage unit, and the cuspid, and they're coming closer to each other, when it says not specified and uncertain and so forth, that means that they didn't even look how the space was closed, from the front, from the back, or a little bit of both. So that's what another problem is with the studies. You have to look into that and say, did they look in a technique in the sense that that we could discern whether they took all factors, technically important factors, in account. 2 other aspects. We already talked about blinding. That is, randomization and blinding are just like very foundational elements in a good study. And what happens is that out of 9 in this particular study, only 2 studies actually have blinded investigators. What does this tell you? the level of evidence and the level of enthusiasm for this group of studies to presenting high level of evidence is just going down and deflating. They were not even blinded. But that's what we are dealing with. Okay, so we do need more quality studies, and we're very proud to say that we hope we contributed with our trial into that direction in orthodontics, and you will see in a moment why. And finally, one other thing, incomplete outcome data. Remember ITT and PP group, which patients didn't finish. Did they report about it? Actually, most of them are unclear. Only 1 out of 9 said that they have reported on those patients that got lost. Okay? So again, components to look at when you're trying to discern how high quality the study is. These are just some of them, some of the tips, some of the things that I have learned in person in our group as we were going through the study and writing the protocols and papers about it. It's very, very good to go through that and know how to equip ourselves to be equipped to read and discern the level of evidence in the studies. Another review that is actually a systematic review and meta-analysis done by a very respected group of authors from Europe who definitely know their business in statistics, published in Journal of Dentistry. Talks about several of approaches for accelerated tooth movement: low laser therapy, corticotomy, interceptor bone reduction, photobiomodulation, pulse electromagnetic fields. What they found, and they went a step further all the way to meta-analysis. Remember, I told you go to for the larger step, for a higher level, but you lose something because if you don't have enough in the sample, then meta-analysis doesn't give you actually better results. But it did it just to compare. And what they found was stunning as well. That out of these 5 procedures, there was only some evidence for effectiveness of low laser therapy in corticotomy. So 2 procedures have some evidence, and there was no evidence or weak evidence for 3 of the other procedures that they have been looking at. So from the bottom you go no evidence, you have a weak evidence, you have some evidence, then you have a moderate evidence, sufficient evidence, you have high evidence, right? 6, 7 layers. There were only 3 first layers, lowest layers that they found. There were studies that were actually fulfilling that requirement. Again, opening our eyes, let's be realistic. We don't have sufficient evidence to have fully or even predominantly based evidence-based treatment of orthodontics, but we need to continue to strive and learn how to discern which studies are better than others. Back to our patient and sample of patients, intent to treat, remember, per protocol group, 45 patients, and what they got, there was Excelident with their braces. They were after the extractions, getting the Excelident. This is the latest model, and this is Aura, which we did not have for our study. We had one of the earlier models, but the important thing is that parameters are exactly the same. The force applied, the horizontal anteroposterior vibration, 0.25 newtons. In our orthodontic jargon, we use grams. Don't tell the physicist, but yes, that's what we do. A frequency is at 30 hertz, and it was used for 20 minutes per day, also based on other studies from orthopedic research. Primarily, these parameters were set and reduced to the size of the jaw compared to the whole skeleton. Just quickly about the clinical procedure, because again, it is published. One point I want to emphasize, we focused to narrow down to one type of tooth movement. And this is very important. Rather than looking at the whole dentition and every possible result, we can focus on one type of tooth movement to get more reproducible and less variable results than if we would look at groups of teeth or dentition overall. So with that in mind, I will go and just quickly go over the parameters. We use TAD for an anchorage unit, 180 grams of force. The distance was measured with the digital caliper straight into the mouth, which I firmly believe is one of the best methods to measure the tooth movement against the fixed point. And retraction started consistently for every patient at least 4 months after the extraction of bicuspid. So there was a fresh extraction holes in which we'll move these teeth, that will be obviously a confounding factor and introduce some variables. This is an example. At the initial visit, the force is put on the cuspid. Next visit, she changed, notice her colors here, and we have space mesial to the cuspid as the cuspid is retracting. We collected the data at regular 4 weeks appointments. Everything else was done as in a regular orthodontic treatment. Patients were filling out questionnaires about their perception of the appliance, and the data were collected for each quadrant of the jaw separately. ANOVA was used to assess the difference between groups, followed by the student t-test. Here are the results. The most important result about the rate of tooth movement that came out of the study was related to the canine retraction into the extraction space under those reproducible conditions. Okay, what happened is right here. This is the key right here for ITT group, comparing the Excellident and the control group, and the mean rate of retraction, which is rate of tooth movement into the extraction space in one versus the other. In control, 0.79, 1.16 millimeters per month. This is unit, millimeter per month. So you can say that you have millimeters per month time gives us rate. This was significant at 0.0496, so there's significantly faster tooth movement in the Excellident group compared to the controls. This is the data from the per protocol group, which actually is even more significant, with a smaller number of patients, and this difference over here, 0.89, 1 to 5, ended up being about 39% faster tooth movement with Excellident. In other words, it's consistent, but these are the data that are actually more meaningful for a clinical trial. So that is the essence. If you ask where is the beef, that's where the beef is. This is the essence of the study, and the first and most important outcome of the study that we have obtained. Again, to summarize that, during canine retraction, 1.16 versus 0.79, the Excellident moved teeth 47% faster. The difference represents 47% in the ITT group. Now, how does that compare with what other people have done looking at the canine retraction without Excellident, regardless of the Excellident? Well, see a couple of groups over here just quickly. These two studies, actually, both of them 0.8 to 1.5 millimeters per month. Now, notice that it is very clear over here mentioned that Anchorage was not even mentioned, so you don't know how the space was closed. So you cannot claim that one tooth moved that direction, but it is in the same range of the data that we have. When they looked at the Anchorage loss, specific different studies, it was established that the anchorage could be lost at very high rate. That's why we use the Nance arches and buttons, and then 1.4 to 2 millimeters movement can be achieved. And finally, probably the tightest and the most reliable data, 0.93 millimeter per month retraction, which TADs being used as well, and the measure from lateral cephs. So bottom line is our data were just in the ballpark figure, right in the middle of what other people have found, regardless of the situation with Excellident or not. Second question that arises was treatment time shorter at the end of space closure. Did the patient finish in the Excellident group faster than the patients in the control group? And the answer is yes. We can look right here. At the conclusion, the average distance the canine has traveled in our study of 5.3 millimeters, the treatment time during space closure was reduced with Excellident by 9.4 weeks. That is pretty significant clinically. We did not measure that particular parameter. We calculated it from the speed and rate of tooth movement and applied it to the group of patients. Okay. I would just go through a patient that we used in the study to give you a feeling of a couple of points I want to make. This patient is pretty severe crowding, as an overjet deep bite, skeletally class 2 patient and dentally class 2, and she was treated by a camouflage treatment, in other words, covering up the skeletal class 2. She qualified for inclusion because upper fours need to be extracted, and she required maximum anchorage. Now she's biting with braces, biting down, and all of a sudden there's open bite here in the back. You ask, why is that here? Well, this is here because she has such a deep bite that she couldn't have braces without putting this bite plate in the palate, and we do that pretty often, as you well know. But the point I'm trying to make here is she was the only case with that kind of appliance in the whole sample. But the point is that as far as her cuspid that is being focusing on, that is being moved, that really doesn't matter, as long as the cuspid was free to move without occlusion and without being hit by something. That patient could have been still included, and she was included in the sample. This is a couple of months after the retraction started, and this is on one side. On the left side, the retraction was completed. She was out of the study about 6 months later. The spaces were still there, but the cuspids were in class 1, and then standard orthodontic procedure continued to retract the cuspids all the way, close the spaces here with the loops in class 2 elastics, and again in the finishing stage she finished very well. For resident treatment, quite well. Of course, you cannot compare resident treatment with the practitioners, but she finished quite well in terms of time, and she ended up being, for 2012 on the AO meeting, at the AO meeting 2012, selected as the best treated resident case in the country at that time. Just an example that we don't have to have homogeneous initial malocclusion in a sample of patients when we focus on one tooth only. Next question that arises, okay, we looked at the space closure. What about the rest of the treatment? What is the other very active stage of treatment, the most active stage of treatment in terms of tooth movement? It's initial alignment. So how does Acceleradent influence the initial alignment? We looked at that, and we were disappointed because we had some obstacles in looking at those patients. Just quickly to describe that, this is not in the published paper because in paper focuses only on cuspid retraction. We started looking at the crowding and to evaluate the relief of crowding and alignment by using Little's index. And we soon established that this is totally inappropriate because when you use Little's index, the movement of teeth along the perimeter, mesiodistally along the perimeter, is completely neglected. So you can have a patient which incisors are being moved 2 or 3 millimeters on the side, mesial and distally, so that an incisor that is blocked can come out, and your reading on Little index will be 0 changes. Very and completely inappropriate. Little's index is a great methodology to measure things such as, the alignment and the extent of decreasing and relieving the crowding, but it was not appropriate for the study for tooth movement. So we used the arch perimeter, and we had to decrease our sample, excluding the patients which were without extractions, taking only extraction patients, small sample. But in spite of the small sample, the difference was still over twofold in the Acceleradent patients being aligning teeth faster at 0.05 p-value, and that was 105% faster during the alignment stage. So both the tooth movement of cuspid and the alignment stage have gone in the same direction. Of course, the cuspid results are much more reliable, much more scientific, because they were done in a way that we have predicted them and with a larger number of sample. This is a patient, Dr. Sonia Palik, who has treated that case with the severe crowding, and I'm showing it just in another example of the patient that we're getting from practitioners, where we can go back and see how the patients reported by practitioners fit into that picture that we have been drawing with the RCT and the clinical trial. And this is one of the examples where she had estimated 18 to 24 months. I think 18 is heroic for this severely crowded case. Blocked out cuspid, crossbite here, 2 crossbites in front, very tough case to treat, but she predicted 18 to 24 months. After 4 months, a stunning result. Most of the crowding is relieved. Look at the space over here and over here. And after 9 months, the case was finished. Of course, not every case is like that. And you can say, well, you can always be lucky and finish cases like that. I don't think that you can finish a case like that in 9 months without some stimulation, and adjunct treatment by Accelident is what, in my view, was what definitely caused that. Another case by Dr. Strader-Regelis, and this is a young patient, again with a significant amount of crowding, blocked out cuspids. Elimination of crowding was the main goal of treatment. Standard fixed appliance was used, and the final treatment also shows that very nice results were achieved instead of predicted 24 months in 18 months of treatment. That's what I said right here in the first slide. Okay? Oops, sorry, went too far. This is predicted time of 24 months at the end, treated at 9 months. So these examples are just pointing out to the direction that we should go when we think about the hierarchy. What are these examples on the list that I showed you before? They're case reports. They're case reports. They're very low if you wish, if you look individually. But are they valid? Do we need to exclude them from our consideration? No. We as clinicians need to look at the case reports from our colleagues, the groups that we are communicating with, and they need to be part of the decision and part of the evidence that we use when making decision whether we will use certain appliance or not. I briefly just want to mention, address the question that is asked pretty frequently. Do we know how the vibration works? What is the mechanism for effect of pulsatile forces? I will use just an example for the studies that we did in my lab several years ago, and looking at the role of osteocytes. In addition to osteoblasts and osteoclasts, osteocytes are the cells that are mechanically triggered. Mechanical force influences them, and I believe they're the most important because they are first responders in mechanical response, such as vibration. This here, from relatively no snow or no white signal to strong white signal, means that the osteopontin gene, in particular region of bone where osteocytes are, has expressed very high with application of force. Same thing, this slide represents for the DMP, another gene, very important for bone. But here's the key. This all happened, high level of expression, increase in expression of these genes already after 3, 6 hours, 12 hours, 2 days, very early after the mechanical force is applied. I believe that the future studies should be directed to looking at these genes in osteocytes, DMP and osteopontin, as the first responders where mechanical vibration actually triggers the signal in them, which is then being sent to other cells, and by which the tissue in alveolar bone responds to vibrational loading. Osteocytes are early sensors, and there are different mechanisms that have been proposed how osteocytes signal that to the bone. Now, safety. And this is the last question from the study. This is the last part of the study that we'll report on. We asked the question, if we move teeth faster, anabolic effect, bone is remodeling, are we resorbing the roots faster? The study that we did was on the same sample of patients, measuring with digital rulers in MyPax images and measuring the length of a total root. And basically what we found, comparing Accelident versus sham over here, this is control, this is Accelident. Number of teeth with greater than 2 millimeters of resorption, it's the same in both groups. Number of individual teeth and with greater than 2 millimeters of resorption, pretty much the same, not statistically significant when you compare the mean differences in root resorption, not statistically significant, which basically led us to the conclusion that we can say that there was no difference as far as the root resorption in the amount of root resorption between Accelident and the control group. So Accelident is safe to be used by patients without a fear that we're going to resorb the roots faster as we're moving teeth faster, at least based on our results. So let's summarize that and tie it into what I was saying in the beginning. How do we view the future? The cyclic loading of vibration of the specified with 25 grams and 30 hertz results in statistically significant increase in orthodontic tooth movement by 47% during the space closure, and during initial alignment as well increases that by twofold. Treatment time was reduced by our calculations 48 to 51% depending on the stage of treatment, and there was no increase in root resorption that was found. Important thing is that as far as the method that we used, that was used for the first time for that particular purpose, we used the TADs, and they have shown the very good results. In fact, as a posterior anchorage and the stable point for measurements. We had a TAD failure rate of only 11%, which is smaller than average 13.5%, and very similar in both groups, indicating that vibrations in the Excelodent did not really increase the rate of TAD failure, which is really good news. So we can continue to use TADs with vibrations, and the patients are not going to be, because of that, at any higher risk for that, for the failure. So as far as reduction in treatment time, I mentioned these percentages before for both alignment and space closure already. Combining these two stages of treatment, we had almost 20 weeks of calculated reduction in treatment time on our sample. That means that, this is significant, and it turned out that the greater the space that are being closed, the greater the discrepancy, the more difficult the case is, the more benefit for time shortening is for each patient. Is this clinically significant? I can leave it to each individual clinician to answer. 20 weeks on average treatment time, to me, seems to be a pretty significant amount of time to say. So how did patients perceive? This is a separate study, and the publication will be coming out on that as well. I'm not going to go into details, but basically from their responses, they were extremely satisfied with treatment, didn't find it difficult to use, and didn't cause any discomfort, and they didn't have change in daily activities while using Excelodent. So on the basis of these results, primarily the tooth movement, cuspid tooth movement in the extraction space, and the safety data from the root resorption study, the U.S. Food and Drug Administration and equivalent Health Canada in Canadian territory had cleared Excelodent for sale in the United States and Canada. Again, this is the reference. You can find it online and in seminars in orthodontics, the hard copy. And here it is. I'm tying back this last slide with my first slide, where I asked, well, how can we do better in discerning where to look and how to look for evidence that we will use certain new procedure in our practice as clinicians. Number one, decide which level of evidence is sufficient to you to start using a new technique. Don't discard any, even your friends and colleagues' opinion, experts' opinion. Don't discard case reports, but look for highest level of evidence that you can. And then how do we know that the level of evidence is higher? Look at those components that we went over with, and that I mentioned with it in our clinical trial. We try to incorporate those, and you will be very easily able to discern, like we just went over this review, and look at the sample size where everything blindly was done, randomization, everything was done, and you will be able to discern and sort out which studies are higher quality and which studies are at lower quality. And I hope that this in the future, we will have definitely more randomized trials, more high level evidence in orthodontics as well, and they will all be better equipped in discerning those and incorporating that information for the benefit of our patients. I want to thank you for your attention and for participating today.